Good morning. The subcommittee will come to order. Thank you all for joining us for today's subcommittee hearing, Choice Consolidation, Leveraging Provider Networks to Increase Veteran Access. This is our third in a series of hearings on different key aspects of the Department of Veteran Affairs' plan to consolidate care in the community programs under a new and improved choice program. In February, we discussed eligibility for care and billing and reimbursement under the consolidation plan. Today, we will discuss provider networks. VA's consolidation plan proposes a tiered provider network composed of a core and external network of providers. The so-called core network would be managed by VA and consist of federally funded health care entities from the Department of Defense, the Indian Health Service, tribal health programs, and federally qualified health centers, as well as academic affiliates. The so-called external network would be managed by third-party contractors across 4 distinct regions and consist of commercial healthcare providers from the private sector who would be divided into a preferred network of providers who meet certain quality and performance metrics and a standard network of providers who meet minimum standard criteria. I understand the advantages of a tiered network, namely that it allows the VA to organize and differentiate between providers by type and quality. However, I'm concerned that the tiered network the VA has proposed will hold government and academic affiliate providers to a different, perhaps less stringent standard than private sector providers will be held to. That is fundamentally unfair. It's also unnecessary. Government and academic affiliate partners have existing relationships with VA that are long-standing, unique, and important, that already puts them at a significant advantage when compared to private sector providers who, for far too long, have been held at arm's length by a department who did not want to treat them like peers and partners in providing high-quality care to veteran patients. What's more, government and academic affiliate providers are fully capable of competing with private sector providers using the same quality and performance criteria that VA has proposed, and they should compete. Some government healthcare entities and some academic healthcare entities are world-class, best-in-show providers, but some are not. We need to know the difference between the two. And more importantly, our veterans deserve to know the difference between the two and to be referred for care accordingly. I also want to ensure that under the VA's tiered network proposal, an individual veteran's choice in who to receive care from will still be preserved. Our veterans have earned their health care benefits, in many cases through blood, sweat, and tears. The least that they deserve in return is a choice. Finally, I want to make sure that the significant infrastructure that has been built, largely with taxpayer dollars, since the current choice program was created in 2014, is not lost as the VA transitions to a consolidated approach. Implementation of the current choice program has not been as smooth or as easy as any of us would have hoped. Indeed, setting up a program of such magnitude under such time constraints never is. I've heard complaints from providers in northern Michigan, for example, that report having to spend significant amount of staff time on the phone, resolving authorization, scheduling, and payment issues. That is far from ideal, and I would encourage the VA and both of the third-party administrators to continue to work to resolve issues as they arise and make choice work better, faster, and easier for veterans and community providers. However, A lot of gains have been made, a lot of lessons have been learned, and a lot of relationships have been built in the last year and a half around the current choice program. As we move forward, we have to ensure that those gains are not needlessly sacrificed in pursuit of the new, which is sure to carry unforeseen problems all its own. I look forward to hearing from all of our witnesses this morning, and thank you all for being here. And I will now yield to Ranking Member Brownlee for any opening statement that she may have.
Thank you, Mr. Chairman, and thank you for calling this hearing on VA's future plan to provide safe, quality health care to veterans by implementing a high-performing network in partnership with federal partners, academic affiliates, and the community. VA believes veterans will exercise their choice when it comes to where and when they receive health care. This is the third in a series of hearings held by the subcommittee to examine details of the Care Consolidation Plan, which was submitted to Congress in October of last year. Last month, we heard from stakeholders on eligibility criteria and VA's plan to improve community care billing and reimbursement. Today, we will receive testimony on the very important provider networks. I understand the VA's plan is to build a high-performing network that will consist of 3 separate tiers, with Tier 1 being with our federal partners and academic affiliates. Tier 2 will consist of top-rated community providers, and Tier 3 will be the community providers who meet standard criteria. VA's objective is to ensure veterans will have the ability to choose which provider he or she would like to see for care. According to the VA, the tiered network structure will allow VA to provide the veteran with information to make an informed choice about the right provider to see. The goal is to reduce confusion for the veteran on where to seek high-quality health care by streamlining the transition from a VA facility to a community facility. We are all aware that the devil is in the details. When the plan was first received, the implementation of a high-performing network was somewhat confusing and unclear. I hope the VA today will shed more light on their plan regarding how this network will be built and how veterans will, in fact, be able to choose their provider. Continuity of care and the quality of care provided through this network should be first and foremost the top priority of VA. Additionally, we must ensure that lessons learned from the past programs, such as PC3, ARCH, and the current CHOICE program, will be considered as we move forward with a new Veterans Choice program. I appreciate the testimony we have received, and I look forward to hearing from all of our witnesses today. So thank you, Mr. Chairman, and I yield back.
Thanks, Ms. Brownlee. Joining us on our first and only panel this morning is Billy Maynard, the President of HealthNet Federal Services, David McIntyre Jr., the President and CEO of Tri-West Healthcare Alliance, Dr. Bailey Yahia, the VA Assistant Deputy Undersecretary for Health for Community Care, who is accompanied by Dr. Jean Miliaccio, the VA Deputy Chief Business Officer for Purchase Care. Thank you all for being here today. Looking forward to this discussion. Mr. Maynard, we'll begin with you. Please proceed with your testimony, and you have 5 minutes.
Thank you. Chairman Benishek, Ranking Member Brownlee, and distinguished members of the subcommittee, thank you for the opportunity to participate in this hearing. HealthNet Federal Services is proud of our work leveraging private sector best practices to supplement and complement federal agency capabilities. To this hearing, we bring the perspectives and lessons learned from throughout our nearly 3-decade history supporting government healthcare entities at the intersection of their care capacity and their need to support their beneficiaries, in this particular case, eligible veterans with care in the community. My commitment to VA healthcare is personal. I'm a veteran myself. I served in the U.S. Army for 10 years. I'm the son of a Navy retiree born at Portsmouth Naval Hospital, and I'm the grandson of a World War II combat veteran who benefited greatly from the services of the VA following his return from that conflict. I take the mission of the Choice program to heart, and in this vein, I offer comments informed as much by the spirit of service, the spirit that led me and many members of my family to service, as by our business experience. I want to thank this subcommittee and the committee as a whole for your leadership on the issues at hand. This committee acted decisively in response to the revelations of extensive wait lists at some VA facilities, and in Choice, you have created the foundations of a program that can serve as a viable model for the integration of VA's direct care capacity and care in the community as we look forward. I also want to express my thanks to senior members from the VA who, from Secretary McDonald on, have worked tirelessly over the past year to make the current Choice program work. In particular, Dr. Bala Yahia and Jean, both of whom are here, have led key efforts to evolve the initial program and proactively address issues that have hindered program effectiveness in its initial implementation. Today, over 2,400 HealthNet associates located throughout the regions we support and the nation as a whole directly support the Choice program, and it is a great honor for us to do so. Working with their VA counterparts, our associates have accomplished much. We have fielded some 2.5 million phone calls from veterans and community care providers, as well as Veterans Affairs staff, appointed what is rapidly approaching 500,000 individual veterans to community providers who might otherwise have remained on a VA wait list, and we have built a registry of nearly 250,000 participating providers located throughout the VA regions we support. And while there is still much to do, real progress has been and is being made towards the kind of public-private partnership through contracts upon which the effective delivery of health care for our nation's veterans now depends. A few points specific to the topic of this hearing. First and foremost, we believe all health care provided in support of veterans is VA care, whether delivered directly by the VA, by its close affiliates, or by community providers. Seamless integration of that care, therefore, is key, particularly at the intersection of the VA's capacity and community care. Based upon our years of experience, we believe the only way all care will be seen and received by veterans as VA care is through mutual accountability in the framework of a public-private partnership contract structure. Second, it is now clear, based on eligible veteran demand, that significant and continuing access to community-based care will be absolutely necessary to support veterans' health care needs in the future. Standardization and consolidation and the development of clear and comprehensive policies addressing the full range of community care eligibility and programs is therefore vital. This was a central point in the independent assessment, and it's been a lesson learned in the initial implementation of Choice. Third, we believe the preferred, also often referred to as a tiered provider network construct that is part of VA's plan for the future, can effectively deliver the necessary access to care in the community going forward. And while there are other approaches, given VA's significant direct care mission and capacity, a tiered approach will ultimately be the most effective way for VA to optimize and integrate care while extending VA's ability to better focus on its core competencies. Of course, throughout that development, veteran choice must be extended and preserved. Whatever geographic or provider network development approach VA takes, we feel it is necessary that VA partner with single third-party entities within each geographic area to administer all community-based aspects of the program. TRICARE is a good example of the lessons learned from attempting to do otherwise in the early days of their journey to the integration of community and direct care. The seamless integration of community care is vital for the provider and veteran experience, and without seamless integration, neither providers nor veterans will ultimately want to participate at the levels necessary to ensure all eligible veterans are cared for. In closing, let me say that in a program like Choice, veteran and provider experience is paramount. The success of any future program will depend in large measure on three interrelated imperatives. First, strengthening VA's capacity planning and optimizing the capacity in the face of veteran demand and choice so that community care can be tailored to ensure ready access in every location. Second, making the provider experience as consistent with community standards as possible while yet respecting and recognizing the VA's need for visibility and access to veteran health care information. And third, streamlining the veterans and provider experience so they are better able to control the process and receive and deliver care when and as necessary. HealthNet is proud to stand as a partner with the VA and this Congress in helping deliver care to our nation's veterans. Thank you, Mr. Chairman and committee, for this opportunity to present our views, and I look forward to answering any questions you may have.
Thank you. Mr. McIntyre, you're recognized.
Chairman Beneček, Ranking Member Brownlee, and distinguished members of the subcommittee, it's a privilege to appear before you this morning on behalf of our company's nonprofit Blue Cross Blue Shield and University Hospital System owners and our 3,600 employees, most of us who are veterans and veteran family members, to discuss how the choice program is evolving in our 28-state geographic area of responsibility. I'm going to focus on the current, and I'm going to focus on the journey we've taken. Mr. Chairman, Janet Van Hagen is an Army veteran who lives in rural America. Before you passed the Choice Act, she used to drive 4 hours each way for health care. Now, thanks to you, she receives her health care close to home. Janet's doctor is joined by more than 180,000 providers in our geographic area that are leaning forward at the side of VA to make sure that those who are in the 28 states that we're responsible for supporting receive the care that they need when VA is unable to deliver it directly. Yesterday, as is the case every day, more than 5,000 veterans in our area received care from this consolidated network accredited by URAC. That's up from 500 a day a year ago. Of course, you might ask, if things are happening as a result of choice, why am I hearing complaints from my constituents? That's a fair question. I'd like to be candid with you. In spite of the early successes of standing up the program, there has and remains work to be done. You've modified the law that was originally passed. We and VA together have been modifying the tools and the processes to make the program as you would have expected it. I'd submit, however, that a 90-day implementation period is extremely short. And at the end of the day, those of us in the private sector had a little more than 30 days to do our part of that work. If you look at the comparative of TRICARE, and I was there 20 years ago at the beginning, they had more than 3 years to design the program and implement it. And it did require adjustments as we went forward. I know it's probably not positive or popular in some quarters, but I believe that this was a good thing for you all to do. I think it was the right answer in response to the challenge that came out of Phoenix and the other areas, and Janet Van Hagen would agree with that. I've been impressed with the courage and the uncommon intensity with which the VA has acted. Just like you, their focus remains sharp, and the sustained pace and intensity at which we all continue to operate is daunting. However, if you look at our geographic area of responsibility, I believe that we in VA are gaining on it. This month, we will field more than 1 million phone calls, with an average speed of answer of less than 16 seconds, and an abandonment rate of less than 2%. More than 100,000 veterans in our part of the country will receive care closer to home, a long way from the 2,000 served in the first month of this program. And our claims processor will pay more than 97.5% of clean claims within 30 days. And we've now processed more than 1.8 million claims for providers. Is our work finished? Not at all. We all have a lot of work to do. The topic of this hearing gets to the next generation, but we have work to do in our current generation. Our network is finished. It's tailored to the demands of the VA medical centers that we support. It includes the federally qualified health centers, and it includes most of the academic medical centers. It's ready to be leveraged to have a tiered network in our area. And most of the network is at market rate, which means that we extend the buying power of the taxpayer in support of the VA, with any discount accruing to the budget of the VA. And our turnover in network is less than 2%. It includes specialty, primary care, and behavioral health. And less than 1% of the appointment requests that we have require us to go outside of our network looking for another provider. Second, getting to scale is a challenge. We now have 10 sites of operation, 3,600 employees. On Friday, I was privileged to be in El Paso to roll out the final operations center, which is now serving our area. Chuck Byers is a Vietnam veteran. Chuck Byers asked me to convey to you his gratitude. Chuck Byers has cancer. Chuck Byers was in a line to get care. And he was in a line to get care not because people don't care. He was in a line to get care because the number of providers available to deliver care in the VA, in the market in which he resides, was not sufficient enough to meet his needs. Chuck Byers saw a cancer specialist in our network. Chuck Byers is alive today. There are many Chuck Byers and there are many Janes across our area. We're on a pathway to improvement. We're on a pathway to refinement, and we have work to do. I believe that the leadership of the two gentlemen that are on this panel, the Secretary, the Deputy Secretary, the Undersecretary Shulkin, and this committee and subcommittee and those on the Senate side are going to allow us to achieve the success that we all desire. And that is that the Chuck Byers of this world, who served our country with distinction, have the opportunity when they have a need to have that need met, whether it's met in the VA directly, at an academic facility, a DoD facility, or in the community. Thank you for the privilege of being here today. Thanks for the privilege of supporting this population. And we and our 3,600 employees and 180,000 providers are privileged to lean forward at the side of those that serve in the VA. Thank you very much.
Thank you. Dr. Yahia, you're recognized.
Good morning, Chairman Benešek, Ranking Member Brownlee, and members of the subcommittee. Thank you again for the opportunity to testify today regarding the department's plan to consolidate community care, specifically to further discuss our community care network. I'm accompanied today by Jean Miliaccio, who's the Deputy Chief Business Officer for Purchase Care. Establishing a robust provider network is critical to increasing access to quality care for veterans. Our proposed network emphasizes veterans' choice, access to care, and quality by partnering with community providers. Let me be clear. Veterans will have a choice in our network. First, they will choose whether they want to access community care at all. Second, for those who choose to access community care, they'll be able to select a provider that best suits their needs and their preferences. Over the last couple weeks, I've had a number of meetings with folks on the congressional staff to discuss VA's proposed community care network. During those conversations, it became apparent to me that tiered networks has a different meaning for different people. Some think of having to pay a different cost share for providers in different tiers. Others think of a narrow network that limits the number of providers or restricts choice. And when it comes to distinguishing between providers, some people describe tiered networks as emphasizing cost over quality. This is not how VA wants to set up our community care network. First, there will not be any difference in VA co-payments from provider to provider in the network. If a veteran does not pay a copay in the VA, they will not pay a copay in the community. Second, we understand that some health plans distinguish providers as preferred based on their ability to control cost over quality. We want to flip that on its head by placing greater emphasis on performance metrics that are related to quality and satisfaction over cost. That's why we're working hand in hand with industry to determine which quality and satisfaction metrics are most appropriate and also commonly used in the community. Last, some networks are often narrow, meaning they have a limited number of providers. That won't work for our veterans. We have veterans in every community across the United States and abroad. Therefore, we want to partner with as many providers as we can. At the heart of it, a community care network is simply a way to organize our community partners and identify and reward high-performing providers. This structure will provide veterans with easier access to information so they can make informed decisions. Veterans who are eligible for community care will have the ability to decide whether they prefer to receive care at a local VA or in their community. And if they choose to receive care in the community, they will have the ability to choose a provider. However, just giving them a list of providers is not enough. In my experience as a clinician, patients look towards us to help them navigate the healthcare system and their options. That's why it's critical for our network to to identify quality providers, which will ensure that veterans are able to make an informed choice. We also want to be better partners for our community providers. Just this month, I sat down with a room full of providers ranging from small practices to large healthcare systems in Florida. They were direct about what works and what doesn't work with choice, and the changes they would like to see in the future. Their comments mirror the more than 600 responses we received from the private sector and 300 responses we received from our own employees on our draft Community Care Network Performance Work Statement. We are actively engaged, and this important feedback is being used to draft the next step of our contracting process, which is a draft request for proposals. As we continue to move forward toward consolidating community care, it's important to maintain our relationships with federal partners like DoD and also our academic affiliates. For decades, they've served as a foundation of our community care network, and over time, these relationships have led to the delivery of high-quality care and also robust care coordination. Growing them will ensure that veterans continue to have access to not only quality care, but in many circumstances, state-of-the-art care, while ensuring that we continue to train the next generation of clinicians that will serve veterans. Therefore, we want to make sure that these valued partnerships are supported by the consolidation of community care programs. In summary, we want to empower veterans to make informed choices and improve their health outcomes. We also want to ensure that we set up a program that aligns with the private sector and encourages collaboration between VA and community providers. Mr. Chairman, I appreciate the opportunity to appear before you today, and we are prepared to answer any questions you or other members of the subcommittee may have.
Well, thank you, Dr. Yahia. I'll now yield myself 5 minutes for questions. And there's so many things I want to talk about because I don't really understand the different tiers, to tell you the truth, and how it all works. But I guess the key question that comes to my mind is the veteran going to be able to call and get an appointment for themselves? I mean, it seems to me that a huge part of the problem in getting an appointment is somebody's making the appointment for the veteran. Are you going to change this? I mean, when I give, as a physician, if I refer the patient to somebody, I tell the patient who I'm planning to refer them to, and then they make their own appointment. So is that going to happen now in this new community care program? Dr. Yahia, can you answer that?
I can. So I think that's an excellent question, and we want to move more and more towards in that direction.
Can you? I think that maybe they can't hear you.
Okay.
Okay.
Is that better?
Yep.
Currently, what we do is we do outbound calls. So once a veteran is eligible, we send the phone number, their information to our contracting partners, and they reach out to the veteran. But just as you described, some patients want to coordinate their own care.
Like most patients, I would say.
A lot of patients, yes. In our future state, where we're hoping to move towards, is VA would be more in the center of customer service and care coordination. I think for veterans that want to make their own appointments, we want to be able to provide that option. However, we want to make sure that we can connect the dots. And so we don't want to just say, here, go make your own appointments. We want to figure out a way to get that information back, so when they do come back to the VA, if they have to see another doctor, we have the clinical information from that community provider. And as you know, some veterans have a lot of comorbid conditions or complicated social circumstances, and they want the VA to help them with
Yeah, I know, but that's sort of a paternalistic viewpoint, in my opinion.
I think what I was getting at is that we want to give them choices. Some folks want to say, I want to make my own appointment. And with that, we say, great, we want to make sure that we have the right process to get the information
Well, can't
back.
the appointment be made right at the time that the patient is referred, right there, so the patient can participate? I mean, the problem is that the appointment is made without the patient's awareness, so then they finds out that he's not available when the appointment was made.
Yeah, we definitely don't want to do anything that you're describing, which is more blind scheduling. So the way that we work now, it's more of we get the veteran's preference, and then we contact the community provider, and we link the two up. But in some circumstances, like you're describing, a lot of patients say, hey, I'll just make my own appointment. And I think that's great. We just want to make sure that we're able to track that, yes, they were able to get in to see a doctor, and that we were able to get the health information back from that visit.
So the other question is, I guess I don't understand the difference between why are there separate tiers? I mean, why is there a core provider and then there's a preferred provider, and what is that all about? I don't understand that. Why isn't there one set of providers?
Yeah, so over the last couple months, I've been talking more and more about this, and the way that we present it in the plan is just a way to organize providers. So from the veteran's perspective, they will not see tiers. They will see a directory of providers, and those providers, as best as possible, will have information about where they are, what specialty they are, their affiliations, their quality, their satisfaction. So it will be, this is kind of behind the scenes stuff. It's how we organize ourselves so that we can make sure that we know that like providers are grouped together. For example, we talk about DoD and Indian Health Service. We work with them in a completely different way than the private sector. We don't use Medicare rates. We pay in Indian Health per person. So the way that we actually interact with them is different. That's why they're grouped together. And then we want to be able to distinguish and reward those top quality providers, and they're another group. So to the veteran, they won't see tiers. They will see information about different providers. But for the VA and for the provider community, we'll be able to organize ourselves so we know the different types of providers in our network.
So the top tier providers are incentivized some way than some other providers?
No, the way that the incentives will work, the incentives of giving value-based payments is independent of the structure of the network. So we want to group like providers together. So if you're delivering excellent quality, other veterans are recommending you, they're giving you high satisfaction scores, somehow we want to say that we're measuring those and we're providing the information for the veteran to make a choice. Based on those metrics, you'll be able to get, as we move more and more towards value-based payments, you'll be able to get rewarded for delivering excellent quality care.
I'm out of time. Ms. Brownlee, you're recognized for 5 minutes.
Thank you. Well, just to follow up on that line of questioning, so I understand in terms of the tiered process, the veteran will not know the different tiers, in essence. It's for internal use. But it seems to me, I still, in terms of the second and third tier, a preferred well-qualified doctor compared to a adequate doctor. And it seems as though, quite frankly, we would want, the best qualified doctors for our veterans. And to make a distinction between two qualifications seems odd to me.
Because we serve veterans in every corner of the United States, we need as many providers to partner with us as possible. And so I think at minimum we want to set the standards. You have to have a license, you have to be able to practice in that state. So we will set a bar so that we make sure that the veterans, when they see community providers, they're credentialed and they're able to serve them. But just by setting one bar and not being able to reward those providers that perform really well, I don't think that goes far enough. And so the idea is we'd love to have every single one of our providers preferred. It's not like we're going to set like a percentage of all the providers will be preferred. If you meet the quality and the satisfaction metrics of the VA, anyone can become a preferred provider. So it's not like we're limiting who can enter that group. It's just based on your performance. And we want to make sure that those performance metrics align with industry. A lot of folks are already reporting on those today, so we're not going to create some new measures that don't exist. We want to use existing data sets.
So to Mr. McIntyre and Mr. Maynard, both, I think the VA just testified that they had interviews in Florida in terms of their network providers to ask what works and what doesn't work. I wasn't there for that process, so I would ask you the same question in terms of your experience so far. What do you think is working? What is not working? Where improvements should come from?
We've done interviews with providers in our network for the last 9 months to determine what changes needed to be made in our processes, and we've implemented those changes. We put the provider first from that standpoint, because if the provider engagement doesn't work, nothing else works at the end of the day. And we're in the process of finalizing what we call Provider 2.0. I will tell you, as part of that, and a follow-up to the question on tiering of networks, we set up our systems at the beginning of 2014 with the adoption of PC3 to actually give our appointing staff the ability to tier the networks. And so among the best providers in our communities, they're the first that we go to for appointing. So if we know, for example, there's a neurology appointment need in a particular community, or there's a urology need that's very specific, we'll seek the top urologists out of our network, and they'll end up in our systems in front of the appointing staff first. That's not an uncommon strategy, and we've been using that from the start.
So in terms of providers, and I understand you're interviewing, you're hearing from them, you're making improvements, daily as you move forward to kind of perfect the system.
Yes, ma'am.
And within the network. And are there any outstanding issues that you have limitations where you're hearing from the provider, but because of VA and regulations that are limitations to you to improve it? Do you have full authority to make all of those improvements?
Yeah, great question. The first set of things we brought back to Congress because there were limitations in the original law that was passed, and you all have acted on those now, and the VA has acted on them policy-wise and pushed them over to us operationally. The set that we're working now, and we're down to the lower part of that list, we in the VA, particularly these two individuals that are leading the effort internally to VA, are working those last remaining mile issues to make sure that we've worked through what needs to be done to make the provider engagement better in our geographic space.
Thank you. And Mr. Maynard, do you have anything to add?
Yes, if I could just add one thing specific to the questions both you and the chairman have asked on this issue. If there is a remaining challenge as we look forward, I think it centers on the concept of eligibility and the parameters of authorizations under which eligible veterans are seen. And this begins even at very routine levels. I know many doctors here on this distinguished panel, but even at the primary care level, you have providers that are looking at a presenting patient who presents with maybe a variety of conditions that may in fact go beyond the boundary of the eligibility. And many of the challenges in delivering care begin right then and there around the boundaries of the authorization or the eligibility and what presents itself as medically necessary. So we continue to work with the VA around the definitions of those eligibility parameters, particularly at levels like primary care where patients present and may actually need to be expedited directly from there to a specialist or to some further care beyond the boundary of the original eligibility. And I think the more that we can do to expedite that and ensure that providers are not prohibited from addressing what's medically necessary while they're there as the veteran presents, and that from there the path to whatever follow-on care is itself expedited, the more we're focused on those issues, the more the program will improve in support of veterans.
My time is up. I yield back. Thank you.
Dr. Rowe, you're recognized.
Thank you, Mr. Chairman, and thank you and the ranking member and the staff for putting this together. And I certainly appreciate the fact that this is not easy. To put a network together across the country is a big bite of the apple. And I think consolidating all of these, certainly in the tiers, I don't have any particular problem with that. The real question that I have are more about function. I have a health care card here. I know exactly where I can use it, what it's good for. Does a veteran actually have that? And the example I'm using is here, it's like what Dr. Benishek was trying to get to a minute ago. If I go in and I don't think I'm getting the care that I need, and Mr. McIntyre presented a very compelling case of a veteran who did get the care they need, I can tell you one who didn't, who last April went to a VA, got a fit test for colon cancer screening because they don't do routine colon cancer screening, had some bowel changes, came back in August of this past year, had a positive fit test. His colonoscopy was scheduled for April 5th of this year, 2016. Went to the choice, finally got to the choice program after having x-rays done. That was in November. He finally got his colonoscopy in January, and he has stage 4 colon cancer. So those stories can be told over and over. That was a failure. The question is, does the veteran actually have a choice? What Dr. Benishek was saying, when I go in there, I don't like the care I'm getting, can I go take my card and make an appointment and see a doctor that I want to see? Because I think that's how the VA gets better, and certainly we can credential easily. I mean, I look at our local system, our hospital system, If you're credentialed to do surgery at the hospital, your license is good in the state, that can be done fairly expeditiously because the patients go back and forth between those hospitals anyway. So that's not a hard thing to do. Maybe in rural areas it's a little harder, but in most areas of the country now we have primary care people and specialists. Can the veteran actually take this card and go see a doctor that they choose? That's a question I'm asking.
In part, I mean, what you're asking, what you're describing is the way that typical health insurance plans work, which is you have a health insurance, you look at the network, you go to whoever you want. But VA's community care network is not a health insurance plan. It's an integrated system with the direct care and the community. So there are some folks that could do that. So our 40-milers today, if you live more than 40 miles driving distance from a facility, you can take that card and you can go to someone in the network and receive care. But the other criteria of how you access community care is from not offering the service at the VA or a wait time. So it's harder for someone to just walk without knowing if you're actually waiting on a list to know if you can actually access community care.
See, I think that's a mistake. I think what we need to do is the veteran needs to be in charge of their health care, and we as providers, both the VA and the community, need to provide that care for them. Many veterans will very much like the care they get at the VA at home.
Yeah.
They love it. I mean, I have to say that they have very high marks. I read very few people who don't. There are some, but for the most part, I think if you surveyed the folks in our area, they would say the VA does a great job, and there would be no problem. In other places, that's not true. And so I think the veteran should be able to have a choice, a real choice, and not get hung up like this particular, and hundreds or thousands of other veterans are tied up in a system. And as Dr. Benishek was also saying, the absolute simplest thing I ever did in my practice, I've said this till I am blue in the face, is to make an appointment. Mm-hmm. And if I saw someone, I would walk them out or send them out to the front desk, make an appointment with Dr. Jones. My staff would pick the phone up and call and get an appointment with Dr. Jones. If it had to be urgent, I might even get on the phone with Dr. Jones. Yeah. That's how it works, and it works really well. Yeah. And what we've done with the VA is complicated this, put so many layers of bureaucracy. We made something as complicated that's not. So I think the choice needs to be the veterans, and they should be able to have that appointment when they leave the VA. They see a VA provider that day, and that VA provider says, well, you need to see so-and-so, and it's not available here at our VA. Maybe it's a back issue, hip, whatever. Before they leave that VA that day, that appointment should be made. And what I was told when I went home and talked to the providers, that a primary care provider has a registered nurse, an LPN, and an assistant. I never had anywhere near that kind of sophistication. If 4 people like that couldn't make an appointment that day, you need to reevaluate your processes, I think.
Yeah.
Would you agree with that?
No, I agree. I think that, I was just in clinic last Friday, and I did the same thing. I had a patient that needed to be seen by a specialist, and I picked up the phone and I called them and got them in for next week. So I think that's how a lot of people practice. I think that's the intent while we're here today, is to consolidate and improve care. There's a part of the plan that we talk about, this referral and authorization process, that's so clunky right now. And there's the eligibility criteria that we've been talking about. There's so many variations on it. If we get to very crystal clear if you're eligible or you're not eligible for community care, then I think we can move up when you can make an appointment to the time when you're leaving the clinic. We have to get there first, because right now we have to double check and triple check if they meet this, if they meet that, and that requires people. And the scheduling clerk sometimes can't do all that, which is different than what's in the private sector.
Sorry, my time's expired, but just your motivation when you saw that patient last week was to get their care given.
That's right.
And all that other stuff in between you weren't interested in, and all the patient was motivated was to get the care.
Yeah.
That's what we need to simplify.
I agree with that.
I'd like to recognize Ms. Brown, the ranking member of the full committee.
First of all, I want to thank both of you all for letting me sit in on this meeting, and I'm going to be really quick, but I have 2 people there from my area, Dr. Yehi, and I want to follow up, and also I have a statement from Action News Jacksonville investigation, and I want both of you, one from Jacksonville, one from Gainesville, University of Florida. We're very happy. But following up with Dr. Rowe's question, because I understand the card, but the main thing is that patient has to have prior approval in order to get paid. And Dr. Rowe would be very upset, and I've heard lots of discussion in this committee about people not getting paid and why they're not getting paid, and so their practice is closing or something. So you have to address that. And then the person, Maitland, who attended school in Jacksonville, same school my daughter attended, Sanderwood, I need you to talk about this Action News investigation of the VA in my area, because I am the ranking member and there is a serious wait time or not happy with choice. So those are my two questions. I met with all of you all before, had hearings in my area, so can you please address it?
Sure, why don't I start?
Yes, sir.
Thank you so much for that question and for representing your area so well. When we have to be good partners to community providers. It's how you build a network. And one of the most critical thing probably is making sure that we pay timely and accurately, 100%. And I think right now there's 3 areas that we have to improve on. Number 1 is the eligibility criteria that we just talked about with Dr. Rowe. Is some veterans will take their choice card and they'll just walk right up to a community provider and they'll deliver care. However, that's not how the law was written. There's certain criteria that you have to meet in order to receive that health care. And so when we get a bill, we can't pay that bill. Even though we'd like to pay it, we can't pay it because that veteran did not meet criteria that were established. So getting to a simple set of criteria that makes sense to the veteran and that we clearly communicate to everyone so they know who's eligible and who's not will be very important. Number 2, and this is something that we fixed about a month ago, is that we were requiring medical records before we actually paid the bills. And as a clinician, I want the medical records back. It's very important, and we still want them back, but we don't have to tie it to payment, and remove that, and the payments have becoming better and better and better on both sides of the United States for HealthNet and TriWest.
Is that retroactive so those physicians will get their pay?
Is that retroactive, do you know? I'd have to
Yes,
check.
the
Is it?
uncoupling of the
Yes,
medical-
it is. Thank you for that. And then lastly is we want to provide more transparency for the doctor. So the doctor right now sends a bill and they don't know where it's at. And I think on both our partners, HealthNet and TriWest, are taking action so that we can improve the visibility into the system, because many times you just want to know, did they receive the bill? Do we have to send them another one? When am I going to get my check? And that ambiguity or lack of information creates anxiety. And so we want to be able to improve that, and that's some of the things that we're doing over the last couple weeks.
Thank you.
Yes, ma'am. Good to see you again, and good to meet with you earlier this morning on some of these issues. First of all, I'd just like to state, that any shortcoming or inability to facilitate health care in support of eligible veterans is obviously distressing and requires attention. Every single individual one, even in the face of the increasing demands and the volumes that are there. I think it was particularly unfortunate, we've been reaching out in Jacksonville to the press outlet in particular about the specific issue, and think it's quite unfortunate that both the personnel from the provider office or veterans involved chose to remain anonymous, which makes it very difficult to find exactly the specific instance that they're addressing there. Nevertheless, it's something that we take quite seriously. I think as Dr. Yahia addressed in a previous response just a few minutes ago, real progress has been made, but there have been challenges around some of the, I think you used the word, the clunky procedures of referrals, and particularly incidents that begin where a veteran was seen and requires further care, does activate a loop going back through from that provider or veteran back into the VA and back out through our processes to authorize that care and actually get it appointed again. And I think as this committee has been rightfully focused on, that's not directly in accordance with all of commercial best practices that could be applied. And I do believe that not only the improvements that we have seen, as you and I discussed, we're appointing some 800 to 1,000 veterans just within the Jacksonville domain itself, not counting all the way down to Gainesville. More than 90% of those are being appointed well within the 5-day standard. There's plenty of access within the network. And nevertheless, as veterans need to be seen secondarily or subsequently, there is much that we can continue to do and will continue to partner on with the VA to expedite that care as it presents itself to providers and as it develops. And just on the provider payment issue, quickly to follow up to Dr. Yahia, I want to again, thank the department. Very close collaborative work with both Dave McIntyre and my company over the past 3 to 4 months to evolve and modify the contract. I think we're all very convinced and already have evidence that those providers that were challenged by the more complex payment methodologies are already seeing a very significant relief in the first 3 weeks after that modification. And I think we expect all providers to be current very expeditiously as we move into the spring.
Well, thank you all for your service, and thank you all for letting me sit in.
Dr. Abraham, you're right.
Thank you, Mr. Chairman. I want to kind of reflect on what Dr. Benachek and Dr. Rowe started the discussion on. I'm just a country doctor here, private care, practiced for many, many years. And yeah, it is a big bite of the apple to institute this, but I don't think it's that big a bite. I mean, this is what you two guys do for a living. I mean, you enroll people, and this is y'all's forte. Y'all are experts in your field. And like Dr. Rose said, again, maybe I'm making it oversimplistic, but have the card, get the providers accredited, and again, we keep having the same discussion over and over about accreditation. Well, if they come from an accredited medical school, if they're licensed and they don't have any criminal investigations, well, why not put them in the network and see how they do? And I know you need your records back. Well, let them have access to the EHRs, or put the onus on the private physicians to either fax or email you a copy of that office visit. Again, I'm the private practice guy, and I'm the primary care guy here. I guess my question to you, Dr. Yahia, first, what is a veteran going to see? You say these objective data, these quality measurements are internal. What is that veteran going to see that will steer him or her to a Tier 2 or a Tier 1 provider as opposed to a Tier 3 provider?
So what we want to do is provide them with information. So they won't even see Tier 1 or Tier 2. That won't be a term.
No, I understand
yeah.
that, but
the way that,
how are they going to know
exactly.
that's a Tier 2 or Tier 3 based on just, pixie dust? Basically, if you're going to say, well, it's Tier 2 or Tier 3, but what is a veteran going to see he or herself
yes.
that will actually say, this is why this is a Tier 2 or a Tier 3 or a Tier 1 provider?
So they will be able to choose whoever they want. What we were going to be able to do is give them information to choose what they want. So first, there'll be basic information about the provider, where they're located, their specialty, what they do. That's set. And then using kind of private sector metrics, so things that are already agreed upon that CMS uses, and let
me interrupt you. Do you already have that objective checkbox formulated for the VA as far as those metric measurements that will distinguish between a Tier 2 and a Tier 3 provider?
We don't have that today in our community care program, but in our draft request for proposals that we're developing, we're putting a list of different quality metrics that we want to measure. And so those get to, like, is your whole hemoglobin A1C in control?
Right.
Are you asthmatic, and do you actually have an inhaler? So we're not talking about things that are so off the wall. These are basic things that a lot of good providers.
And I guess that's my point. These metrics are already in any electronic health record
yes.
I've ever accessed, and I've seen my share of them, I'm sure. And again, you check the box. It's a matter of hitting the key,
yep.
and the computer picks it up, and then it's part of the record. I guess my other concern is, as a family doc, like Dr. Rowe was saying, like you were saying, when you had your patient the other day and you immediately went and made a referral, if I've got a patient with hematuria, blood in the urine,
sure.
and going back to your urologist example, and I need a urology appointment, am I going to have to go back to the VA to get that specialist? Or can I walk out to my receptionist and say, go to Dr. Smith, right down the street, the urologist, again, if I have to go back to the VA for that specialty care, then I worry, well, all of a sudden the cycle starts again, and it may be 30, 60, 90 days before he or she can be seen.
No, I think you have a great point. So if you're if you're being seen in the community for urology, and let's say you discover that someone has diabetes, and you can't just directly refer them to the endocrinologist because we didn't authorize that care. However, the way that they would do is they would call the VA and they say, hey, this person I've figured out has diabetes. Is there a diabetic specialist that could be seen him timely? If not, then they can access the network for that.
And I guess that's my rub, is that call that I have to make, that interrupts my patient care, because then I lose that patient back to the VA and may or may not get those records back if I don't have that access to that electronic health record. So it's just that continuity of care that I worry about.
I'm agreeing with you in that spirit, is that we have to find better ways to share information. You made my point for me, which is a lot of those things are in the EHR. The only thing that we want is to be able to get that information and present it to the veteran. And so it's not asking for the community provider to take something more onersome than what they normally do. And to be able to report this information will be voluntary. It won't be a requirement for them to share that with us. So for those that feel inclined, we'll be able to take that information and share it with veterans so they can make decisions. What we are working on doing is how do we get to a place where they don't even have to fax us anything?
Exactly.
That we can actually start sharing information.
Right.
This is something that I think all of healthcare is struggling with now. So it's not just the VA, because I don't think anyone has figured it out completely. When you're in an internal healthcare system, it's easy to share records. But when you start going from one healthcare system to the other, it becomes harder. So I think we are going to continue to evolve as healthcare evolves there.
Okay, thank you. Thank you, Mr. Chairman.
Mr. Takano, you're recognized.
Yeah, to follow up on these concerns, I'll just take my own. The kind of questions that Dr. Abraham is asking and Dr. Rowe, excuse me, I was blanking on his name. Dr. Rowe is asking about patient choice. I think we face in the private sector healthcare the same anxieties, but the stakes can be even higher, right? If I go out of network, I can pay 50% more for going out of network, and it's on me to find that out. And I don't know that dealing with my private sector healthcare folks are any easier getting through on that customer service line. So I don't know that putting these expectations on the VA, which is not an insurance plan, right? Well, you were not set up as an insurer. You're having to do a whole new thing in terms of creating payment plans. I mean, the concerns of my colleague from Florida, our ranking member, about making sure providers get paid. You're trying to simplify and consolidate all the different care in the community. In other words, care in community means our non-VA private sector providers out there who are under all these different plans, right? So my question is for Mr. Manning and Mr. McIntyre. Are you optimistic that this consolidation plan under the VA is going to make it far more easier for you to recruit people into your networks? If providers can be assured that they're going to be paid timely and there's a simplified process, do you think that's going to really enable you to provide robust networks?
I think that the consolidation makes a lot of sense. It's confusing to everybody that's involved in this process when you've got multiple plans that pay at different levels, that have different requirements, and require different types of management. And the VA is to be commended for taking a look at how do they bring those pieces together. As it relates to recruiting itself on the provider side in the area that we're responsible for, we've been able to successfully reach out and bring providers into the network in the areas where we in the VA believe that they're necessary. The one thing that I would say is that these things take a while to refine. And back to the issue of tiered networks, the Defense Department has a term called right of first refusal. And the objective there is to make sure that the federal footprint that's been paid for by the taxpayers is maximally leveraged. And what we did in TRICARE during the term that we were involved in that was to actually profile each facility and determine what kinds of services were available and in what supply. And those are the only ones that we went back and determined whether there actually was the ability to push that specialized patient back in. So I think I think you're on the right path. The VA is on the right path in terms of trying to move these pieces.
Well, let me ask this. So, Dr. Yahia, from the point of view of the veteran, they're just going to see whether the doctor is in network or out of network, right? They'll see if the VA provider they want to go to is eligible, and that's kind of a point one. But not every veteran will be eligible to see certain practitioners. Is that right?
They won't see in and out of network. They'll just see one network, and that network will have all the VA facilities and the community providers. So there's not an out of network benefit.
So so from a standpoint of veteran, it's much simpler than the task I have, right?
Yes.
Because I have to figure out who's in network, who's out of network,
Exactly.
who can go be paid, which facility, which emergency room will take me. So for the veteran, it's potentially a lot simpler.
That's right, and I think you made an important point, which is I think some folks think of the community care network or the community care program as an insurance plan. It's not. It cannot stand alone. If there was no direct VA care, that program cannot stand alone to provide all the health care needs of veterans. We have to think of it as an integrated system where together, internal VA care, community care, now that actually forms the health plan. That actually forms what's called, minimal essential
So
coverage.
if you're a provider, if you get everything in order, all your ducks in order, the payments, and you attract a lot more physicians, a lot more partners, the veteran could probably have a lot more choice than someone like me.
They probably will. Yeah, I mean, we have not only that, because of some of our specific relationships, they'll have access to some services that people in the private sector don't have access to. Let me give you a quick example. In my practice in Philadelphia, across the street at the university, we had clinical trials that no one else had access to except for our veterans. And so our veterans were getting access to some of the new hepatitis C medicines before they came on the market. And so I think our network and what's part of our network not only delivers good quality care, but access to some state-of-the-art care that other folks don't have access to.
Well, and I won't have time to get into the cost, but potentially even the cost at below what some of were in the private sector as well, because you negotiate the drugs and all that sort of stuff. So access
Right.
to the latest drugs at better costs. So potentially the choices are even better for the veteran under the track you're going. Well, thank you. I yield back.
Dr. Wenstrup? Correct.
Thank you, Mr. Chairman. So my thought is that I would like to see the primary care doctors be the gatekeeper for the referrals. That's the doctor you have a relationship with. It's what you just did in the example you gave. And I would even like to see it, whether there's an option, of the 30 days or 40 miles. This is even if someone's available within the walls of the VA, but you know that the doctor down the street is probably the better one for this patient for whatever reason, shouldn't the primary care doctor have that authority? Do we need to grant that authority on this level? How can we help here?
So actually in our plan, because I believe the heart of care coordination is the veteran primary care doctor relationship.
Agreed.
And we talk all about that here. And I also agree that they are the heart of the referrals. And for if you have a primary care doctor within the VA, they will be the ones that coordinate referrals. Some referrals will go inside, some referrals will go outside. That's true. I think it becomes a little bit harder when you have a primary care doctor outside. The only thing but I think we can improve on that. The only thing that we want to do is provide more visibility to the community primary care doctor about what services are offered at the VA. Because traditionally, most of the veteran or most of the patient they see, they would send to their friend down the street or someone
Right.
else in the community,
Right.
partly because they don't know what's offered. And I think if we can give more visibility on, actually we have really good, diabetes doctors here and a really good, cardiologist at the VA, they can start referring things back in an appropriate fashion. So I agree with you. The center relationship is that veteran with the primary care doctor.
Yeah, and you're right. I mean, it just becomes an awareness of who's at the VA and who's available because they're not the person you've traditionally referred to. Yeah.
That's exactly what we did in TRICARE with that concept I was talking about in terms of right of first refusal. And then you want to map out what's available facility by facility so that you're not posing a challenge to someone when they're trying to find care that needs to be delivered. In our network, there's 50,000 primary care providers stretched across every zip code in the 28 states. And so if you're outside of 40 miles, you have the ability to go and see a primary care provider if we're able to put that in place.
And if I could just add one
Sure.
point to that, I think that's why it's very critical that if we're going to actually have veterans' choice really needs to begin with the choice as to where to be linked from a primary care perspective, to be linked within the VA directly or to choose to be linked for primary care purposes in the community so that then the processes can proceed from there and that gateway that you spoke to will actually be established.
Is there anything we need to change from a legislative end to make that more workable?
I think there's, I think to be able to highlight that relationship would be important, and we can chat more offline about some options.
Okay.
Thank you.
Thank you. I yield back.
Ms. Custer, you're recognized.
Thank you, Mr. Chair, and thank you to the panel for being with us. I have a question on the academic medical centers. And in New Hampshire, where I'm from, we have a top-rate academic medical center, Dartmouth Medical School, and a close relationship with the VA. Dartmouth is also affiliated with a very, very large medical center, one of the rare rural tertiary hospitals in Lebanon, New Hampshire, and also a series of clinics around the state, including my district. And my question is, when you talk about including academic medical centers, are you also including their network of care in a situation like this where they run clinics all around the state?
Yes, we want to sign up as many providers as possible. When we talk about the specific partnerships with academics, we focus on those teaching relationships where we actually have residents and fellows that go back and forth. And so I think there was a point that the chairman made about making sure that they have the same standards as everyone else. And we want that to be the case. So we're not going to like carte blanche, just because you're an academic, we send you all our business. There's specific relationships where we send trainees back and forth, and there's a volume need. So they need to have a certain case mix, in surgery, to be able to actually have an accredited residency and to be able to support trainees. So it's only in those circumstances that they are considered core providers. If we don't have a relationship, let's say we don't have any residency in dermatology, they would compete and be on par with everyone else in our commercial sector tier.
Okay, I understand that from your perspective. I want to understand it from the veterans' perspective.
So
Was your answer meant to lead to the veteran being able to access the care in their community through these clinics?
Yes, I think from the veterans' perspective and the community providers' perspective, we are interested, and I'm sure Dartmouth is an excellent institution. We'd love to sign up every single one of their providers. And so from the community provider perspective, we want them all to join the network. And that means more choice for the veteran.
And along the lines of the indicators of quality, I just want to make a point. Representative Kaufman came to New Hampshire for a regional field hearing on our heroin epidemic, which we now know that 4 out of 5 heroin users started on prescription medication. And we've now uncovered that part of the problem is an inadvertent use of quality indicators in Medicare that is leading to reimbursement decisions being made on the basis of pain surveys, which is leading to the unintended consequence of over-prescribing of opiates. And we have a bill, Representative Mooney, our colleague from West Virginia, and myself have a bill to change that. But I'm concerned, and I want to put this on the record right up front, that not be used as a quality indicator in anything that you may be doing, because veterans have had a very challenging experience with this.
Yeah, and I would agree with that. I think there's this is one of the things that we distinguish ourselves from the private sector. I think they probably had a well-intentioned reason to do those satisfaction surveys, but I've seen many of my colleagues that are excellent clinicians, and they're doing the right things, and that may mean not prescribing an opioid, but maybe physical therapy or acupuncture, and because the patient didn't walk out with a prescription, they give them a bad score, but they're actually excellent doctors. So we have to be very clear about the metrics that we use. I definitely would agree with that.
Yeah, and if we could just say that right up front, that any type of, you have to think through what might happen in using these different metrics. And then the last question has to do with one that frequently comes up when we're talking with the Secretary and the VA, and that's the issue of co-pays, out-of-pocket expense to the veteran. I know that we want to keep that as low as possible, but I'm concerned, just given that the taxpayers are at the other end of this equation, that we're not sort of incenting people to use the VA when they have perfectly good health insurance from another source that might be more appropriate. And for this, I'm talking about not the veteran experience related, and I think I may be going over my time, but if we could submit that for the record. Yeah, thank you very much.
Mr. Bilirakis, you're recognized.
Thank you, Mr. Chairman. I appreciate it very much. Thanks to the panel as well. With regard to the costs, I have a question. Of course, the quality of care, veterans deserve the best. No question, that's imperative. But do you have any metrics as to, are you tracking what the costs would be within the VA and also outside the VA under the CHOICE program?
Yeah, we're monitoring the spend on the CHOICE program very closely. We have a set limit that was provided by Congress, and so we monitor that very closely. So we do have that.
Can you give me some answers?
Sure. So we spent, last fiscal year, we had about $3.5 billion that we used out of CHOICE funds to deliver care to veterans. This year, we're anticipating kind of something similar, about $3 to $3.5 billion. So that gives you a little bit of a sense of, at least just from CHOICE, it's only CHOICE care that we spend financially. I think, to your point though, I think where you're getting at is, as we continue to make the program better, more and more people are using the program. And that is something that we have to be very cognizant about, because as we make a product that people want to use, there's a cost that's associated with that. And as we start considering developing new legislation that will consolidate community care and create a new program, how do we make sure that we have the right resources to actually deliver that benefit? We're seeing more and more people using the program than ever before.
How are you getting the word out? I know we're doing our job here to get the word out with regard to the program, the eligibility requirements, what have you. Tell me that, and also how are we getting the word out to the providers or potential providers that want to participate in the program?
So we've done a number of outreach for both veterans and community providers, including, we have a website. That website specifically has an area just for providers, an area just for veterans. We've issued letters to all of our community providers that we were working with before CHOICE, encouraging them to join CHOICE, similarly to veterans, mailers. So we kind of are trying to use different avenues to reach more people. I will say probably the biggest thing that we do is really word of mouth, which is the local medical center talking to their veterans in town halls and their local providers, ask them to sign up. And as Dave and Billy can attest to, we've seen a big increase in the number of providers that have joined both of their networks.
And on our end, we had the Blue Cross Blue Shield plans and universities that own our company that are indigenous to the 28 states reach out to their networks across their states to be able to give them the sense that this was there and how they would sign up. And we're signing 300 to 500 doctors up a day.
And it's the same with us, and both Dave's organization and mine also had deep foundations in the TRICARE program, and we're able to, of course, approach all of the participating providers there who also are reimbursed under Medicare and have been very receptive to expanding access and support of veterans as well under this new program.
With regard to dental care, those who are eligible under the VA, are they also eligible under the choice program?
Yeah, yes, sir. So if you meet the eligibility criteria for dental, which are pretty high,
I know that.
there's a number, and we can't, either we don't provide dental care at the VA or there's a wait issue, they can get that care in the community. Also, we know that a lot of the dental care is already delivered in the community today. We don't have dental practices at most VAs, so most of that benefit is delivered in the community already.
Very good.
Thank you.
Okay, anyone else want to comment on that? All right, thank you very much. I yield back, Mr. Chairman.
Mr. O'Rourke, you're recognized.
Thank you, Mr. Chairman, and I'd like to thank everyone who has testified today, and thank you also for your answers to our questions. Mr. McIntyre, you mentioned being in El Paso on Friday. Thank you for being there, for making the commitment to our community, and we really appreciate Tri-West having an operations center that is hiring veterans in El Paso. And Dr. Yahia, through you, I want to thank Mr. Joe Dalpiez, Vision Director for Texas, who was also there, for his commitment to the community and for everything that you all are doing. I have two questions, I think, on this subject. We were told by Dr. Clancy last week that while we thought we had 41,500 authorized, funded, but unfilled positions at VHA, the number is now 43,000. Given this consolidation, this admission that the VA will not be able to provide all things for all veterans within the walls of the VA medical facilities, this excellent article by the Undersecretary Shulkin in the New England Journal of Medicine last week to that same end, a couple things. One, can we dispense with the fiction that we will ever hire or maybe even need to hire those 43,000? Related to that, number two, Dr. Shulkin mentions in the article the need for the VA to focus on those conditions and disabilities and illnesses that are connected to military service and to combat. And I think of post-traumatic stress disorder, traumatic brain injury, military sexual trauma, traumatic amputation, those things that you're generally not going to see in the civilian population. And should there not be sooner, I hope, rather than later, some kind of behavioral health dividend related to those conditions, where if we're not focused on hiring all 43,000, we're going to really focus on those specialties like mental health that we really need, that will prevent veteran suicide and do a better job for all of our veterans. And then the second question, if you can get this in the time remaining, I held a veteran town hall on Saturday. 28 veterans approached the microphone to share their experiences at the VA. 13 of those 28 mentioned that their primary care physician left the VA in El Paso. They were never notified. They only found out when they went to refill a prescription and couldn't, or were waiting for a referral that never came through. High-level person at the El Paso VA Medical Center said, there's actually a problem right now where we cannot refer somebody to community care. We first have to have 30 days to demonstrate that we couldn't get it done in here. We need the flexibility to recommend right away. I know this has come up in other questions. Could you just address that specific to those dropped veterans who have lost their primary care physician and don't know what to do and wait months to get an answer?
Yeah, thank you so much, Congressman. This gets back a little bit to the eligibility criteria, and the way that I describe those eligibility criteria is three areas: wait time, geography, and availability of service. And so I think at El Paso, there's a number of things that are not available there. So by definition, we automatically partner with the community to deliver that. Geography, if they live more than 40 miles away, and then wait time, the 30-day criteria. That's only, the way that I think of it is that's only the floor. So that's a minimal set of eligibility criteria. We need to make sure, and this is something that I think Congress can help us with, is make sure that there's adequate flexibility so that if there's a special circumstance, if I'm seeing someone in my clinic that I think has to go out in the community, even though we don't have a wait in that area, we have some of that flexibility to do that. And some of that was afforded to us when the most recent iteration of the choice law was passed over the summer. So I think keeping that front and center is important so that it is not so rigid to just those three areas, but there is some flexibility so that the local VA can work with their veterans if someone needs to go in the community. I don't know specifically about the issue in El Paso and the primary care providers. However, if there's a wait for primary care, they automatically are eligible for choice. And so that's something that we can make sure that they're aware of that option, and they can offer that up to their providers or to their veterans.
And then the other question is, I would like to get into the specifics of that offline, but the other question is, can we now tighten our focus on hiring mental health providers, and if that means increasing what we pay for them, just having the attention to that, prioritizing that over other conditions that might be better served by a network that they can refer out to. What are you seeing towards that? I'm out of time, so I may need to get your answer for the record, but we're acutely interested in that right now. Thank you.
Mr. Kaufman, you're recognized.
Thank you, Mr. Chairman. First of all, if I understand this right, Dr. Kihia, under this VA's proposal, it is the VA now, that will do the scheduling for the third-party providers or administrators.
Yeah, in our proposed plan, we want to be more of the face of customer service and scheduling. That could mean, as we talked about before, just saying to the veteran, you're eligible for community care, here's our options, do you want to schedule your own appointment? But we would be more the ones that would be having that conversation rather than the contractors.
Okay, I'm very concerned with VA doing the scheduling, and let me tell you why. The whole reason for the choice program was that there was a scandal in the VA on scheduling. That the level of corruption, systemic corruption across the VA in scheduling, driven by cash bonuses in order to bring down the wait times, and they created these secret lists. And now what you want to do and what the VA wants to do is let's give it back to those same people.
So first of all, the reason why we want to do this is because we've heard from veterans and community providers. So and in all the town halls that I have and that I sit down and talk to folks, they say, why is there a middleman in the scheduling? And the folks that actually do the scheduling for community care are different than those that do the in-house.
We need to get the system to work, but we need to get it to work without getting VA back into the system that got us to where we are today. I mean, unbelievably incredible. And I got to tell you, those who have been responsible have not been held accountable. We don't even have a mechanism, and the Secretary doesn't support one, to claw back bonuses for people that fraudulently got them on this scheduling scandal. And yet we want to move it back? I mean, I just think that that's just absolutely incredulous, and that is truly an exercise in poor judgment. And let me tell you, this member of Congress will be in a blocking position. If you're familiar with that term, I don't know if you served in the military.
I didn't serve.
The blocking position, well, take it from a Marine Corps officer, infantry officer, that's to stop you from doing that, because I think that that's an incredible exercise, again, in poor judgment. And I think you're reluctant to let go. I think the VA is reluctant to let go of this, and so creating an excuse rather than fixing the system, let's give it back to the VA. And I think that that's an incredible mistake. Mr. Maynard and Mr. McIntyre, both HealthNet and TriWest have experience managing care networks with TRICARE. Based on your experiences with both DOD and VA, where can VA learn from the methods and practices employed by DOD with TRICARE?
I think there are a couple of key points that would really facilitate, that even though the benefit or eligibility structure is different, are still there as critical lessons learned. I think one of them is really clear eligibility criteria linked with standardized reimbursement. The more we standardize reimbursement around Medicare, there is sufficient provider support in the community to largely accept Medicare reimbursement in support of eligible veterans. That represents a savings itself from commercial rates, but it standardizes and simplifies and streamlines a good bit of the provider relationship. The other, I think, is continuing to remove the very points that you've been emphasizing that impede ready access. I think I myself believe that scheduling going forward, while it started as a critical and well-intentioned component of the initial choice program, really did have an unintended consequence of obstructing a bit the ready flow in terms of the way the facilitation of healthcare works. I think as we look forward, that scheduling service should be a secondary or tertiary availability to veterans who individually need help. But to the point that you raised, there are very sophisticated and increasingly capable commercial sector capabilities, including, for example, our own relationship with 1-800-Doctors that has auto adjudication and auto capabilities to link into community care, hospital, and provider systems to automatically schedule necessary appointments. And so I think keeping an eye on the evolution of the way that customer services are delivered, ensuring that industry is not impeded from bringing best practices to support of veterans are critical concerns as we look forward to serving veterans into the future.
I would agree with Billy. I would add, though, that I think there's the opportunity to take advantage of the first right of refusal process so that when we've got veterans that are far out, making them aware of what's actually accessible in the VA would be a good idea, but not force them to go there. Secondly, though, as it relates to rate structures, 2/3 of our network's actually built at market rate, and it's a full pass-through to the VA budget. And what that means is we have doctors and hospitals all over our 28 states that said, you know what, we'll give you up to Medicare, not Medicare. And you don't want to lose that because it's built into the base of the budget.
I just want to, again, I'm over my time, Mr. Chairman. I will yield back.
Mr. Heelskamp, you're recognized.
Thank you, Mr. Chairman. I apologize for being late. I had another subcommittee hearing, Small Business Committee, also talking about health care. But I appreciate the questions of Mr. Kaufman. I do have my assistant here, my youngest son, Alexander, on spring break. This is exactly what every 9-year-old likes to do on spring break, I must admit. So, but thanks for Alex for joining me. I'd like to follow up with the questions from my colleague to the west about scheduling. And he already stole my question about how can we learn from TRICARE experience as well. But under TRICARE, does the DOD schedule the appointments?
No, there are no scheduling services. Originally, there were various services. There are a few military treatment facilities, or MTFs, that maintain some appointing support for their own appointing, but not outside the walls, and neither has it really proven a critical issue at all in terms of the facilitation of care on behalf of the TRICARE beneficiaries.
You'd have to go back a decade to find that, and it took a bit of refinement, just like this is doing, to get it right. And, you know, part of the challenge, I think, in the scheduling space was we stood this program up in a little over 30 days because you were responding to a crisis, and appropriately so, with the right kind of intensity. And how we're doing scheduling now in our area is vastly improved over the first couple of months of what we were doing. And part of that is we took the geography and broke it into segments. So now we're not serving people out of 1 or 2 geographic areas. We have 10 operations centers. We stood them up since the summer. Went from 400 staff to 3,600 as of last Friday. And so we built a hub and spoke environment. That's what you have to have. You've got to have a relationship with the providers in the community. And it takes a little while to get that refined. At the end of the day, I do believe there are areas where it makes a lot of sense for the VA to be absolutely at the nuclear center of scheduling. And Alaska is one of those examples. Far too complicated for everybody than to be having a third party involved in that process. But in many parts of our environment, that's not the case anymore. And we're not getting the negative feedback from the providers that we were getting even 6 months ago.
I would agree, and prompt payment helps lessen feedback, and I appreciate the VA announcing some of the reductions in paperwork that's making that happen. Still have some pushback, but the idea we would go back. I had a local VA clinic, or maybe it's, I guess maybe it wasn't local, it certainly wasn't a local VA clinic, but they want to do some scheduling for a veteran, and I think they said, well, the nearest provider is 5 states away. They misunderstood they were looking at the city and didn't recognize they were states away. I mean, I think that was online with the VA. You hear that again, and it might be different, doctor, maybe in an urban area, but in my district, they know the hospital. And don't forget, these veterans, this is not their first rodeo to go to the local hospital. Most of them are already going to the local hospital, and that was the fear that somehow they would overwhelm the VA system as they rushed in. All we're saying is let them keep going where they're going in many cases, and they don't need the VA calling the local doctor they saw at church on Sunday. And again, it might be different in an urban area where you've got the VA hospital a couple miles away and you've been waiting your 30 days. But for our rural areas, if we went back and centered scheduling, we would have even more problems than before. We would have even more complaints. So the robustness of this network is developing, and I think it's continuing to improve. And the providers I talk to, they're signing up. Just make sure that they get paid on time. But again, let's not envision this as a veteran that's getting 100% of their health care. It's the case sometimes they're starting to drop in and want to say, hey, can we get this taken care of if this is going to work? So we'll hopefully see this continue to develop and work with the folks that have experience in other networks. And again, don't forget you have a veteran that maybe a senior officer he served alongside has TRICARE for life. He served 4 years. Why can't I go to my local hospital, but the guy that has long-term benefits the rest of his life, he gets to go to local hospital, but I got to drive 200 miles. Obviously, we want to avoid that. So let's continue to work and develop that network. But I know in western Kansas, central Kansas, they're ready and waiting. They're slowly adding providers actually quickly. And I've got 70 community hospitals. Unlike some of the other areas, they are begging for patients. And they're hoping to get the veteran once. They might even get his wife and get his kids as well, and it's these kind of things that they develop. My concern as well is that the temporary nature of the language, and I know the Secretary has promised that he wants to make this permanent, but the sooner we can make this permanent, the sooner we can make these relationships more long-term, and for the veterans as well as for the providers, Mr. Chairman. So appreciate the timeliness of this topic, and I yield back.
Thank you, Mr. Hillscamp. Does anyone have any further questions? I know there's lots of...
Just quickly?
Yeah, sure.
If you don't mind. Thank you. Just quickly. I have just a couple of quick questions, and I hopefully they're just all yes answers. But in my district, we're still having issues with regards to inappropriate billing when a patient, a veteran, is seeing a community doctor. And we have a particular issue, a casework that we have not been able to resolve for one of our veterans that saw an orthopedist, was very satisfied with his care there. He stepped on a landmine in Vietnam, ended up getting 2 splints that he needed, but he's being billed $500 for those splints, and we've worked really hard in our district office to resolve this problem. If you could help us resolve it, I would appreciate it very, very much.
If you give us their name, we'd happy to work that.
Terrific. And in terms of just following up on Mr. O'Rourke's question about staffing, if you're going to send him information, I'd be interested, in the same information as well. And the last question I had is if you have wait time data for veterans who are using the choice program, and if you have any analysis of comparing that nationally in terms of wait times compared to what the VA is providing with regards to wait times. Thank you. Thank you for your indulgence, Mr. Chair.
No problem. I'm sure there may be other questions that we come up with as you're developing this program, and I look forward to that dialogue. But other members may want to submit some questions for the record even yet. So thank you all for being here today. It's been an education, and I'm sure it will be as we go forward. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material, and without objection so ordered. This hearing is now adjourned.